All right, so welcome. I'm Amy Lawrence. I know everyone here in the group has some understanding of who I am, but just in case folks who are watching the recording don't, I'm a member of our church's reopening task force. It was commissioned by the session at the beginning of the pandemic, which is why we called it the reopening task force. Really, it's ended up being more of a COVID task force as this has gone on for now 18 months. But it's a group of us who seek to acquire the best information and help make the best decisions to keep everybody healthy and safe associated with the church and with our programs. I'm an emergency physician, but I'm retired, so I'm not currently taking care of patients with COVID-19. But of course, having a scientific and medical background, I'm very interested in all of this information and happy to share what I can with everyone else. We also have Katie Zalin with us today. She's an RN, registered nurse, who works in the ICU at Legacy Emmanuel in the medical ICU. So she is taking care of ICU patients with COVID-19. So she'll be chiming in also. As I was getting ready for this question and answer session, which really is kind of an update, it made sense to me to go ahead and put a deck of slides together just because I had to get my own thought process clear. And so this, I hope, is helpful. And we did get some questions in advance, and I'll go ahead and put those up on slides and give you my answers to those. And then there'll be plenty of time. There should be at least 30 minutes, if not longer, for us to open it up for any other questions that folks have. So here are the basics that I'm going to kind of review on my slide deck. We're going to talk a little bit about the Delta variant. We'll talk a bit about prevention, make sure we refresh our memories about what we need to be doing to keep ourselves healthy. I'll talk about breakthrough cases. They make the news a lot. This is a concern for everybody. We'll talk a bit about treatment. And at this point, Katie may chime in, or we may hear from her later. It's completely up to Katie to decide. We'll talk about booster vaccine doses. That's another big news item, and people are curious about that, understandably. I will talk a bit about children and COVID. I know not everyone here today has young children or grandchildren, but I think it's helpful to understand what's going on in that arena. And then there'll be some questions. All right, so let's talk about our variants. Well, if you heard my talk I gave in March, which was back 6 months ago, this is some of the basics about what variants are. Mutations can happen in the gene information for a virus. And when those mutations happen, they're random. And those new variants then can go any which way. Some of the mutations are lethal to the virus, which means those viruses never show up to us, or they prevent further ongoing propagation. But some can also give the virus new or enhanced traits, make it more deadly, make it more lethal, make it able to cause concern. So you hear them talk about a variant of interest. That's when a new variant has been identified. A variant of concern is when a new variant has some characteristics that make us concerned it might be a problem for us. And these traits can happen: more transmissible or infectious. It could be able to cause more severe disease or a greater death rate, or it might be able to evade our usual immune protections, either from natural immunity or from vaccines. So those are what can make it a variant of concern. We remember what we used to call the UK variant, or B117 was the scientific nomenclature. We now call that variant Alpha, and we are calling our variants by Greek letters. And Alpha, if you remember, it seems like ages ago, was more transmissible than the original SARS-CoV-2 virus, which is the virus that causes COVID-19. So we knew that it was more transmissible. It did appear to cause more severe disease and a higher death rate, so that was concerning. We were lucky in that it did not appear to affect immunity. The vaccines that we had, once we developed them, continued to work well. And unlike in the UK, the Alpha variant or UK variant did not become dominant in our country. And so it did not produce a massive surge as had been anticipated by a lot of experts. So we dodged that bullet to some degree. But now we have a Delta variant, and this Delta variant, which originated in India, is more transmissible than all previous variants, including more transmissible than Alpha. We think the reason that it's so much more transmissible is because it produces an increased viral load. And what that means, a viral load is just the amount of virus that a person who's infected has in their body and produces by their body. And we think that the Delta variant, when it infects people, produces a much higher viral load, maybe as much as 1,000 times the viral load, which is why that makes it so much more transmissible. If you have more particles of virus that you can spew out into the environment, there are more particles of virus that people can take in and become infected by. It does appear to cause more severe disease as well, and it carries, we think, twice the risk of hospitalization compared to the risk before Delta. So if you test positive, your hospitalization risk is twice what it used to be before. Fortunately, those numbers are low for most people. And also, lucky for us, it does not appear to avoid immunity, meaning our vaccines still work against it. I'll talk more about that in boosters, but our vaccines work against it, and the people who have been infected do carry immunity after being naturally infected. And it's now, as everybody should know, the dominant variant in US cases. It's responsible for well over 90% of the cases in the United States now. So let's talk about prevention. We've got this Delta variant, it's more transmissible, we've got more virus running around than there used to be. What do we need to do to keep ourselves safe? Well, COVID-19 primarily and fundamentally is a respiratory illness, which means that it's spread through the respiratory tract and spread through droplets and aerosol particles. And the respiratory tract is the nose, the mouth, the trachea, and then all of the lung tubes, the bronchi, bronchioles, and the lungs. And so someone who has COVID-19 breathes out the virus particles, and then someone else breathes it in, and that person then becomes infected if they breathe in enough of the particle that it triggers enough for there to be an infection. The most effective protection, we all know this, but I have to say it, the most effective protection against it is vaccination. By far and away, the one thing people can do to keep themselves healthy and safe is to get vaccinated if they aren't already. The other primary preventative measures that we use are focused on minimizing air swapping, right? I want to make sure that your air doesn't come to me if it's infected, and that if it's infected, that I don't take that infected air in. So we keep our distance from each other physically. We wear masks, which protects both the person wearing the mask and the person on the other end of the mask. And we avoid especially sharing in closed and poorly ventilated spaces, because that means air is circulating and recirculating, so that if there is virus there, there's a greater chance of then breathing it in with each breath. I want to talk again a little bit about masks. I went over some of this material back in March, but I think it's important, especially with regard to children, in regard to all of us. There was a study of different mask types done by the research arm of OSHA, and the calculations were done at the University of Minnesota. What they did is they measured different types of masks and looked at the leakage of particles. And the particle size only matters here. The reason why I spell it out for the science nerds like me is that those particle sizes are in aerosol range, which of course is the important one for COVID-19. So if we look at how much leakage there is coming into the mask, meaning how much of the outside kind of air do I get leaking into the mask when I breathe in? If you use an N95 mask, less than 1%, almost no leakage at all. And that's what Katie's holding up if anyone's looking at the gallery. So there also are KN95s, which are similarly made, but just regulated slightly differently. But those are excellent, they're very effective. A surgical procedure mask is a little better, but it has 40% leakage. Okay, I love it, Katie. Thank you for the demonstration. So she's got her surgical mask, it's 40%. But you can see there's some gaps there, right? And so there's gonna be some leakage. If you use a 3-layer cloth mask, those are actually, they help some, but there's still 75 to 80% leakage. So there's actually quite a bit of leakage around those. And so they're not necessarily the best protection. Interestingly, they also looked at a 1-layer neck gaiter that actually had less leakage than a 3-layer cloth mask. I'm guessing only because there was the downside of it is sort of against your chest, and so there's really only one edge of leakage. And then in terms of outward leakage, how much of what you're breathing out leaks out around the mask, the numbers are similar. With N95, it's 1%, all very, very low. Surgical procedure mask is about 50-50. 3-layer cloth mask is about 60% leakage, and the gaiter was also 60% leakage. So the message there with the masks is the greater your concern or the greater your risk, the better your mask should be. And so that's kind of the hierarchy. Cloth masks are okay for limited periods of time, but you might want to consider a surgical mask or an N95 or KN95. So another topic that's hot on the news is a breakthrough case. And first, let me just explain what is a breakthrough case. Not everybody knows what that is. A breakthrough case is a case that occurs when someone who's fully vaccinated becomes infected with the coronavirus. Now, that infection could be asymptomatic. It could be mild, it could be more severe, or it could be fatal. So it can be of any degree of illness, but if that person tests positive for COVID-19 and they've been fully vaccinated, meaning it's at least 2 weeks after their last injection, that counts as a breakthrough case. In the state of Oregon, as of August 15th, there had been 7,135 reported breakthrough cases. Now, of course, there are probably other breakthrough cases that didn't get reported or didn't get tested for, but officially there have been 7,135 reported breakthroughs in Oregon since the middle of August, cumulatively. And that's out of a rate of 2.3 million fully vaccinated Oregonians. So that means the rate of breakthrough is 0.3%, very, very small. We hear about breakthrough cases a lot, and it's reasonable and responsible to be concerned about the possibility of breakthrough cases, but fortunately, the reality is that they still are incredibly rare. What about across the country? If you look at the statistics across the country on a daily basis, there's about one new confirmed breakthrough case for every 5,000 fully vaccinated individuals. So again, these are low numbers, 1 out of 5,000 on a daily basis. And with regard to breakthrough cases who end up needing hospitalization, that goes to one new hospitalization out of every 100,000 to 160,000 vaccinated individuals. So very, very small numbers of people who have breakthrough cases that end up needing the hospital. If you look on the other end and you look at all of the patients in a hospital setting, about 14.6% of all hospitalized patients are breakthrough patients. And of all the deaths that happen to COVID-19, about 16% of all those deaths happen in breakthrough infections. So of the cases in Oregon, I'll break those down too with hospital and death. We had a rate of 0.3. Of all the breakthrough cases, only 413 required hospitalization and only 58 died. So again, this is out of 2.3 million Oregonians. So these numbers are small, which should be encouraging to everyone. This part's important because the logical next question to ask is, okay, well, the numbers are small, but is there any way to know who might be at risk for breakthrough? That part's important. And of the breakthrough cases requiring hospitalization, greater than 70% occurred in patients older than 60. And of the ones that caused death, 95% were in patients older than 60. And this isn't meant to scare anybody who's over the age of 60, but what this does do is it illustrates that any other risk factors people have can still function with regard to breakthrough cases. So if you have other risk factors, such as being older or such as having other significant lung disease or cardiac disease, those risk factors still do put you at increased risk compared to someone else without those risk factors. And why are breakthrough cases important? They're rare, but why should we be tracking them? Well, a vaccine's effectiveness when we first have it predicts a certain number of breakthrough cases. So we know that some are going to happen. But the reason why we need to be monitoring that is that if we have higher than expected numbers, we need to pay close attention. And if they're higher than expected, that can be an early or indirect clue that new variants might be circulating. So when Delta was happening, they started having increased numbers in the UK, or I'm sorry, in India. High numbers can also be an indicator of immunity waning, of immunity decreasing. And we'll talk about that a little more with boosters. The other important factor to remember is that increasing numbers can indicate changes in behavior. So if all of a sudden everybody on the planet were to stop wearing masks, breakthrough cases would increase because the prevention of breakthrough cases works the same way that prevention of non-breakthrough cases works. And so changing our behavior significantly can increase and change numbers too. So let's talk about hospitalizations. The numbers of hospitalized COVID patients are routinely reported, and that's a really helpful public health measure to know how many beds are occupied and how many are occupied by COVID patients. One of the statistics that commonly, almost every time is quoted is the percentage of those patients who are unvaccinated. That's an important number to know, but I want to share with you, it's really important to be aware of focusing on that number alone. And the reason I say that is if we were to imagine a world in which we had 100% vaccination, every single person in the country had a COVID vaccination, then that would mean that 0% of hospital patients were unvaccinated. And so when we hear statistics that tell us that 85% of the patients in a hospital are unvaccinated, it's also important to know what percentage are unvaccinated out in the community. And so it's really the proportion of unvaccinated patients in the hospital compared to the number of unvaccinated in the community. So here's what I mean by that. If you tell me that 85% of the patients in a hospital with COVID-19 are unvaccinated, and then you tell me that 40% of patients in the community are not vaccinated, then we know that the hospitalization rate is greater in vaccinated patients, right? Because the proportion is greater. If I tell you that 20% of patients are unvaccinated in the hospital and 40% of patients outside the hospital are unvaccinated, then we've got some wonky numbers that we need to look into more carefully. It's a little confusing, but I hope I was able to get the message across. So I want to talk just briefly about one facet of treatment. This is really Katie's area of expertise. But what I want to talk about with treatment is something that can happen before someone ends up in the hospital system, and that's monoclonal antibodies. These are derived from patients who have recovered from COVID. So you take someone's serum who's recovered from COVID, you get the proteins that are the special antibodies that fight COVID, and you isolate those and then multiply those. And then you create a medication out of that that can be given to other patients. It's used currently under an FDA emergency use authorization, just like the vaccines were initially when they first came out. And it's important because these are used early in people who only have mild to moderate disease and who are still outpatients who don't need to be in the hospital. And when they're used early, they can be effective in preventing someone needing the hospital or having more serious disease. They have also been used to prevent infection. So when there's someone who's at high risk, who has knowingly been exposed to COVID, it can be used as a preventive measure also to help prevent them from contracting COVID-19. And I think I read there was one statistic I saw that if monoclonal antibodies are given to someone, it can decrease the risk of hospitalization by up to 70%. It's really important. It's typically given as an IV infusion in a clinic setting of some sort. You don't have to be in the hospital to get it, but you usually have to be at a doctor's offices where there's IV capability of giving IVs. And the reason I want to emphasize this so much is that if you or someone you care about has risk factors for more severe COVID disease, you're older, you have heart conditions, you have lung conditions, you're immune compromised. If you test positive with COVID, please, 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 please talk to your doctor about the possibility of getting monoclonal antibodies. It could be very helpful to you, and especially for unvaccinated people. If you know someone in your life who's unvaccinated, if they test positive for COVID, please talk to them about monoclonal antibodies and tell them to call their doctor as soon as possible to arrange that. I didn't put this on the slide, but there are locations down in the South where they have been giving the monoclonal antibodies as several intramuscular injections in order to avoid having people in a clinic setting to make it more accessible. I don't have data about that, so I can't comment specifically on whether it seems to be as effective as the IV, but the point still stands that it's something you need to call your doctor about. Oh, and then I put a little notice here. If you test positive and you're at high risk, please ask your doctor. All right, boosters. So why are we talking about COVID boosters? It seems like we just got our injections and got our vaccines. Well, the reason we talk about it is because every type of immunity eventually diminishes over time. That's just nature. So even for someone who's completed the initial vaccination series, and even if they've had an effective response, we expect that at some point that effectiveness will decrease over time. And we should be very comfortable with this. It's why all of us get our tetanus shot every 10 years. Those of us who went through hepatitis B vaccination, we get tested to see if we still have an effective response if we end up in a new setting where that's required. So this happens. We get boosters for stuff all the time. So therefore, the appropriate question about booster doses for COVID vaccines isn't really if, it's when. So how do we decide when? Well, it's being examined by the FDA and the CDC. And what happens in the process is that the FDA has to have information from the manufacturer to be examined so that they can first of all determine that, yes, this is safe, yes, this is effective, yes, this is a reasonable thing to pursue. Once that's authorized by the FDA, it goes to the CDC, and the CDC makes the decision about who, when, and how. And so they decide on sort of the nuts and bolts. The reason that we've been talking about this as early as we have is because Israeli data, which are quite good, the Israelis and the British have really put together the best data on all of this. And the Israeli data indicate that effectiveness might be waning as early as 6 months after completion of the series. A lot of experts don't think we need boosters at 6 months, but the fact that there's an indication means that it's time to start looking at that. And again, like I mentioned before, the other factors besides waning effectiveness might be to blame. It may be that people who have been vaccinated take more risk in terms of their exposure, and that may be why there are more infections in that group of people. I wanted to put this comment in here. Please take what manufacturers have to say about it with caution. I don't think any of the pharmacy manufacturers would ever knowingly harm patients, but they certainly have their primary obligation to their shareholders, and giving extra doses makes them more money. So I think it's okay to listen to what they have to say, but it's important to focus on what the medical experts say about it. And this has come up too, is a booster the same as a third dose? And technically it isn't, and here's the difference. A third dose is a third dose that's given as part of the initial vaccination. Hepatitis B is a good example of a virus that actually requires 3 doses in the initial series. So a third dose is not a booster. It means that third dose was needed to get you to the first spot of being effectively vaccinated. And currently the FDA has already approved, and the CDC is promoting, administering this third dose of the mRNA vaccines, Pfizer, to people who are moderately to severely immunocompromised. And so what this means is if you are someone who has a moderate to severe immunocompromise, it's harder for your body to mount an effective response. And so those folks need a third dose to get to the starting point of being fully vaccinated. Someone who does qualify for the third dose would then use the timing of the third dose to calculate the timing of a booster dose. So if we say, it looks like we'll probably have authorization for booster doses at 8 months after vaccination. So it would be after that third dose, and then 8 months after that would be the time for the booster dose for that person. I want to mention a few things about children and COVID. With children going back to school, this I think is important, and with numbers increasing. Obviously, children under age 12 are not eligible for vaccine. We know that. And so that means that all of those other prevention measures become even more important. If you're looking at classrooms and enclosed spaces where children are going to be spending a lot of time, really ideally, the most important factor should be that there's good ventilation. And the best mark of that would be that if they can say they provide 5 to 6 air exchanges an hour, meaning that air in that room is turns over 5 to 6 times an hour, then that's adequate ventilation. It's understandable that a lot of school buildings weren't built for that kind of air exchange. And the good news is portable air cleaners with HEPA filters can be used if central ventilation isn't adequate, that equipment's not there. Spacing and masking help too, but remember that most of the masks that most of us wear have quite a bit of leakage. And if you're sitting in a room for several hours and there's that amount of leakage, there's going to be a lot of sharing of air. The most important piece really does go back to vaccination, which is that vaccinating everyone else around children can provide a buffer. So that's important. If you have children who can't be vaccinated, getting all of the adults in their life and older siblings in their life vaccinated can help and provide a buffer. We don't know the timing for when children under 12 will get authorization and be approved for vaccination. It may be a couple months, it may be several months, but the FDA and CDC are definitely making sure that happens as soon as safely possible. And this was an interesting statistic that and this goes back to vaccinating people around children. The risks of hospitalization for young children is 3 to 4 times higher in areas with lower vaccination rates. And it makes sense, right? If people around the children have infections and aren't vaccinated against that, then the children are at greater risk for that themselves. And same thing, and like in adults, for adolescents, the kids who are between 12 and 17, rates of hospitalization are higher if they're unvaccinated compared to vaccinated. And nationally, about 32% of adolescents have been vaccinated. So about 1/3 of our kiddos between 12 and 17 have been vaccinated now. The good news is in children, Delta does not seem to affect risk of severe disease and death. So that's reassuring. But the hospital rates are going up. And when you have a greater number of kids being hospitalized, you'll have a greater number of children with more severe disease and unfortunately a greater number of deaths. So far in the months or the pandemic leading up to Delta, there were about 350 pediatric deaths. That's comparable to a normal flu season in our country. In the last month, there have been at least 50. So the numbers are going up. Okay, so I'm going to talk a bit about the questions that we got already in advance, and I'll answer those. I'll open it up, and Katie, please feel free to chime in at any point, and we'll loop back to you, Katie, too. Actually, Katie, do you want to talk about treatment?
All right, can you hear me now?
Yeah.
I don't have a real formal presentation or slides or anything, but just to kind of review, I do work in the ICU. And so if you're having, if you're admitted with COVID to the ICU, we're way downstream from the initial problem starting. And the key, as Amy mentioned, with getting monoclonal antibodies, we still do give remdesivir, which is an antiviral. Those are all early treatments. We'll see them a little bit in the ICU if they were started out on the floor and then continue them in the ICU. Remdesivir is like a 5-day course. So we typically don't see that. And the monoclonal antibodies, again, it's a set time. And we're running out of those. So COVID is a disease of inflammation. So what we're doing now, there's a, I would call it a chemotherapy, but it's an anti-neoplasm drug that we're giving in lieu of the monoclonal antibodies because it has a very high anti-inflammatory component to it. Early on, like a year or so ago, you may have heard of convalescent plasma. People that had donated blood that had COVID, they found they had antibodies. That's gone out of favor for a number of reasons, but the big one, it wasn't really that effective. But yeah, early on, you'll see remdesivir antiviral and the monoclonal antibodies. But if you make it to the ICU, again, it's inflammation. So there you're going to see a lot of steroids, and that's kind of the only thing we can offer. Again, they're at high risk for other infections. So of course, we'll be treating like a pneumonia on top of their COVID or other diseases. We try not to intubate as long as possible because it's a poor prognosis. So they'll be on very high flows of oxygen. They're breathing super fast and their saturations are low, but it's interesting. They don't feel that short of breath. So we continue oxygen therapy and we'll have them lay on their stomach. When you're on your stomach, you can just think about your own chest area and then look at your back. It's a bigger area that has more room to expand if you're laying on your stomach. It's called proning, like the prone float. So if they can, we turn them over, but you can't, if you're awake, you can't lay on your stomach all day. So we try to encourage that as much as possible. If you get to the ICU and you end up being intubated, we take over for you. And You're on a lot of medications to keep you sedated, sometimes even chemically paralyzed, so we can just totally control your body, and we'll turn you over and lay you on your stomach for 18 hours at a time. And it does, for a lot of people, it helps. For some, it doesn't make a difference. The biggest gun we have is ECMO, which is like a lung transplant that is done in the, not lung transplant, bypass. And it takes the blood out of the patient in a big, saying IV is being nice, it's a big tube, taken out, it's oxygenated, and then part of breathing is ventilating, getting rid of the carbon dioxide. It blows that off, and then it's returned to the patient. And early on, before COVID, it was effective for flu. The early COVID patients wasn't quite the track record, but I will say the Delta variant, it's not really, it's kind of a Hail Mary situation. The recovery when you get to the ECMO portion is pretty, it's not that great of a record. I'd say maybe 1 in 3 actually survive to get off ECMO, and then you're a pulmonary cripple if you even make it out of the hospital. Oxygen, wheelchairs. So it's a big decision. We don't put just anybody on ECMO. Older people, a lot of risk factors are considered before that's done. And to back up to like the monoclonal antibodies and remdesivir, if you get those and it helps you feel better and you recover, that's not the same as a vaccine. You can still get COVID again if you've had those treatments. So please do get vaccinated. If you had the antibodies, you still need to get vaccinated. COVID patients in the ICU, this is just a sidebar. They're there forever, it seems. They don't get well very quickly, and they actually, particularly the Delta, they plummet to very critical condition very quickly. Amy mentioned, and I'll just make a little correction, the ICU that I work in is actually a neurotrauma and respiratory failure ICU. So we have neuro patients and strokes and trauma patients. They're all vying for those same beds as well. And the ECMO, particularly the ECMO COVIDs and COVID in general, take a lot of resources. And so I don't want to say they suffer, but the other people, they're the ones that they're waiting in the ER, waiting for a bed because there's no movement, because these critical patients aren't going to just be discharged out to the floor very quickly. So I don't know. Any questions? It's very sad. It's frustrating. A lot of it's preventable, but that's true of a lot of life injuries and illnesses. But anyway, and I just feel right now we're at a very critical staffing matrix, and things are very tight. And they're continuing. I'm hoping that we're kind of reaching a peak and hospitalizations will be going down, but please, I just lift our friends to the south up in prayer. ICU rooms made for one patient have 2 people in them, like in Grants Pass, and just incredible numbers. Patients are in ultrasound or in a closet, just anywhere they can find a spot. And we're certainly not at that point, but it doesn't feel good. So keep them in your hearts and prayers.
All right, well, let me go.
That wasn't very uplifting, sorry.
No, but we need to hear it. I appreciate it.
It's just, yeah, I would just only stress it's an upstream. When the stream is a small trickle, that's the time to jump in and make a difference, waiting until it's a roaring river and you're in the ICU on ECMO.
For sure. Thank you. All right, so I'm gonna go through the questions that we received in advance. And the first one is about the Delta variant. So is the Delta variant being spread the same way? Is it airborne? And we know the answer, yes, it is. It's being spread just like the other ways that the other variants have spread. So should we be more diligent with spacing or masks? Do we need to disinfect and wipe everything down? Is hand sanitizer still necessary? So again, the most important factors involved in COVID-19, because it's a respiratory illness, are the respiratory factors. So it has to do with air and how much you share air. So spacing and masks can both help for sure. Like I said, the type of masks matter a lot. And in terms of disinfecting and wiping everything down, not as important for respiratory illness. Theoretically, it's possible that if I have a big wet sneeze and sneeze on my hand and touch you and then you touch your face, that it can get passed that way. But the reality in the world is that most of it is passed through air exchange, through sharing air. So hand sanitizer is helpful for general hygiene. I'm a big fan of hand sanitizer at any time before I touch my own face or eat. But the key is really dealing with whether you're sharing air with somebody else. All right, on boosters, is everyone going to need a booster shot to combat the Delta variant? If so, why won't the first shots we had be sufficient? So as far as we know to date, the Delta variant, it seems to be just as responsive to the vaccines as the other variants have been. So when the booster shots happen, they won't need to be specific shots for the Delta variant. Having said that, the pharmaceutical companies are developing shots specific for Delta because that makes sense that they would want to offer that as a maybe slightly more reassuring option. But currently we do think that the booster shots of the same shots that we got before should help give us the boost that we need. And I hope I answered the question about why the first shots won't be sufficient, that can diminish over time, and we expect it to diminish over time. A good real life situation. In outside conversations with friends, do we need masks? All right, well, there's several factors involved in this decision, and this goes along with any of the sort of real-time medical decisions we make about our exposure. So the first question is everybody vaccinated? That's always the first question. If everybody's vaccinated, makes things much easier. This is a setting where you're going to be outside. That's another important piece. Being outside is a lot safer than being inside. And that's because outside you essentially have infinite air among which those particles can get distributed if anybody's carrying particles. So my answer would be, if you're in an outside conversation with friends and everybody's vaccinated, nope, don't need masks, you're good to go. The other factor to keep in mind is your own personal risk profile and the risk profile of everybody in the group. So if one of the people in this group of friends is a 90-year-old with really significant heart disease and lung disease, then you might want to go ahead and mask up just to be extra safe because that person is so high risk. But if it's otherwise healthy people, everybody's vaccinated, you're outdoors, no need for masks at all. And people can chime in and ask about other scenarios too. Okay, another one. This is a big one. Are there any data available to give guidance for someone on immunosuppressants who got the Johnson & Johnson vaccine? No booster has been announced yet. So the short answer is no, we don't have the data yet, but that's being obtained by the Johnson & Johnson so that it can be reviewed by the FDA. One of the possibilities that is also being reviewed is that it may be that it's recommended that folks who got the Johnson & Johnson get one of the other vaccines like the Pfizer vaccine as a booster to give them added benefit. So it hasn't been decided yet. It is being looked at. My best guess is that sometime in the next month, it will be recommended officially that the folks who've had Johnson & Johnson get a dose of the Pfizer as their sort of third shot, or second shot, because the Johnson & Johnson was a single shot. Are there any data on the number of breakthrough cases in immunocompromised people for being around vaccinated people? So the question is, do we know the numbers about how many times someone who's vaccinated causes an infection in someone who's immunocompromised? So the short answer to this one also is no, we don't have that. The only way we would have that data specifically would be if we were contact tracing every case. We have way too many cases to do contact tracing. We have more than 100,000 cases a day across the country, more than 2,000 a day in the state of Oregon. So we don't have that. The good news though, is that if someone has a breakthrough infection, that infection is most likely going to be asymptomatic or mild. Someone who has an asymptomatic or mild infection, just by definition, is not producing as much of a viral load as someone who has a more severe infection. So someone who has less of a viral load, has less particles to put out in the air, means it's less likely someone else around them can get those particles and breathe them in and become sick. So breakthrough cases are not as risky to the people around them typically as non-breakthrough cases. If you're someone who's vaccinated and contracts COVID, it's less likely you'll pass it than if you're someone who never got vaccinated and gets COVID. Those folks tend to be more infectious. And there just aren't numbers. And I know that part's frustrating. It'd be nice to know what your odds are. All right, so that's what I have for that. So let's open it up. I'm going to stop sharing. Please chime in. What would people like to hear about? Yes.
I am really curious about, I read a virologist talking about the fabrics that are made, that the KN and the N95s are made of,
Okay.
and saying that you could get this fabric and actually put it in your mask as a layer. And I wondered if that, I mean, I've been doing that because I find the cloth masks easier to work with.
Sure.
And is that something that you have heard about, and do you agree with that?
So yeah, so yes and yes. There's still going to be a slight difference because then you still have the factor of what I would call fit. So if you have gaps anywhere, then you still have gaps. So the advantage of getting a KN95 or an N95 is that it's constructed to fit snugly against you at all places. Yeah, I love Katie's demonstration. Thank you so much for thinking of that, Katie. So you can see, and you can bend it over your nose, and you can get it so that you have a really good fit. But yes, putting a filter in a cloth mask, if that's the one that you can best tolerate, is going to improve how well that mask works. The other caution I would give people is some people say, oh, I'll just double or triple mask. You got to be careful, because if you make it so hard to breathe through your mask, you end up training all the stuff outside of the mask in. So it needs to be breathable. And that's another reason why using the right material matters tremendously. Does that make sense? I know it's a little convoluted. Yeah.
Katie, what are wait times in ERs for people who are like, if you walked into an ER and your oxygen saturation was like at 80, would you be considered a prime, like move them in fast, if compared to somebody who's got a bullet wound and they're gushing, you know?
The short answer, yes.
So what are the wait? I'm just curious about wait times, you know, and how that is operating right now.
Definitely. There's a triage. If you come in, actually either of those would get you right back to the ER if you were gushing and if you were, low saturations. And they find a way. And again, it's people, I mean, if you're really that low on your saturations, you need oxygen. So that'll be the first thing they'll do. And they'll go to the back and maybe pull somebody out of a room into the hallway and get you in to that room. Yeah.
But
so
is it,
if you're like really critically ill, they get you back in there. Yeah.
I was, I had heard something about, 7 hours. I had heard something about 20 hours. And I just was curious if you had any experience with that.
Well, I mean, I can say I've had experience back when I was practicing. And some people would say, oh, it took 20 hours in the ER. Well, they may have been under the doctor's care by that point already. It's the length of time that someone waits to be seen by somebody is really kind of the dead space there. And that can be hours, unfortunately, especially now with things as busy as they are. It could be 3-4 hours. And then things can sometimes just take a long time once you're already seen. It can take a really long time to find a bed if they need to be admitted to the hospital. Some people end up staying overnight in an emergency department because there's no bed to send them to. It's not ideal because the type of nursing and doctoring that happens is different in an emergency department than it is up in a hospital unit. So everybody's struggling to do what they can, but the systems are overloaded for sure.
Thank you.
Charlotte, I saw Charlotte. And then,
thank you.
sorry, go ahead, Katie.
I was just going to say, I would just, second that motion from Amy, is that, if you are so ill that, like you said, your oxygen level's 80 or you've got bleeding or whatever, you do get back there. But then once you're stabilized, treatment will begin. Even if you're in the hall, treatment will begin. But it'll be a waiting game, most likely, to be admitted to the floor. And again, care continues in the emergency department. And sometimes it's not, is the labor and delivery nurse working in the burn unit? I mean, they're both nurses, but yeah, it's not their expertise, but they can they can certainly care for that. I just spaced out what I was gonna say. Yeah. But
Thank
yeah, wait times. But if you come in and, I maybe even like a dislocated shoulder, that's a little time sensitive, but my back's been hurting for 2 weeks. Yes, you will sit in the waiting room for
Hours.
12 hours. Yeah. So
I saw Charlotte, and then I know Darcy, and then Debbie. So Charlotte.
Okay, after a person recovers from COVID, my son is in the process. How long does his natural immunity last? And should he get a vaccination and when?
Okay, so we don't know exactly how long natural immunity lasts. Most people estimate that sort of 3 months is safe. We know that it lasts at least 3 months, but it does not seem to last as long as vaccination. So yes, he should get vaccinated. He should get vaccinated as soon as possible. And usually the cutoff is 14 days after complete recovery of symptoms, if he didn't need the hospital at all. So if he had a mild or even moderate case, 14 days after he's feeling completely well again. If he had a more severe case and needed to be in the hospital, usually they make you wait a little longer, and I would talk to his doctor about that. But usually they say it's more like 20 to 30 days.
And now all I have to do is convince him to get a vaccination.
Yeah.
Why he got COVID in the first place.
I know. All you can do is
Sorry,
tell him that he can get it again, and
Yeah,
the vaccination will help prevent him from getting it again.
Good,
So,
thank you.
yeah. And then Darcy.
So I have two questions. One is, can you talk a little bit about is it Mu or Mu variant, which looks, at least with very preliminary data, like it might be more resistant to the vaccine? And then the second thing has to do with our in-person worship, and whether the reopening committee has some kind of parameter or algorithm that you're using to determine when and if we go back to totally Zoom again.
Yeah. So the Mu is the newest variant of interest. And so just that fine point being, a variant of interest means there's a variant that we're looking at. Variant of concern is the next level, like, oh, yep, we see something that's definitely concerning. So Mu currently sits in the interest category. It does have, it originated in Colombia in South America. It does have some genetic traits that look concerning, but there hasn't been enough spread of it to know exactly what the impact is yet. So we'll see that in the cases in Colombia first. That's being watched really carefully by the World Health Organization. They're kind of the CDC for the whole planet. And so they're looking at that. And United States, of course, the CDC is looking at that information as well in terms of how it might apply to us. We're part of the Americas. So theoretically, it would come to us before it would come to Europe. So it's being looked at. We don't know too much yet. There's enough there that it could end up becoming a variant of concern. But there were, I don't know if people remember this, but there was the P1 variant back many moons ago that was in Brazil, and really prominent in Brazil, caused a lot of trouble there. And we were terrified it was going to cause havoc here with us. And it didn't. It came to the United States and it just never took off. So it's just a waiting and watching game. And right now we're waiting and watching. With the reopening task force, we don't have specific criteria. And I think it kind of goes to the same comment I made kind of on the side about, the risk between immunocompromised and a breakthrough infection. It's just not, the numbers aren't exact enough for us to be able to say with total confidence that we know once we have 90% of the population vaccinated, that there'll be no more transmission. We just don't know. So we are meeting more frequently now than we used to be. And we have the hybrid option. And so of course, people are welcome to use the hybrid option if they feel individually uncomfortable with being in person. As everyone knows, I myself stay on the virtual option for now. I'm on the hybrid Zoom. And we just continue to take it week by week, frankly. I know that might not be the most satisfying answer, but it's the honest one.
And I think, Amy, you've mentioned before, our little neck of the woods, Multnomah County, our numbers are pretty good. So yes. I think we're doing a pretty good job. And
Yes,
then,
our
you know, a
vaccination
little
numbers are
microcosm
good,
of
our
church.
case numbers aren't as high. Yeah, our section of the state is the best performing section of the state. So it can be, you know, I know, Como metro area. But, and so it's understandable that we hear these numbers of like, oh my gosh, we have 2,400 cases a day. You know, 200 of those are Multnomah County. So it's both and. So we're watching it carefully. I don't know if this gives anybody any peace of mind. I watch the numbers every single day. I see the numbers every single day. I read the reports every single day. So I was a infectious epidemiology science nerd as a hobby, even before the pandemic happened. So yeah, so we're paying close attention, but we welcome any, you know, we're happy to hear what everybody has to say about it. So it's okay to let us know what you think, for sure. We want to know that.
So when those reports from the OHA come in every day, and we see those numbers are not relevant out of context. Is that what you're saying?
Yeah, I mean, they are because Oregon is Oregon, and, you know, people mix. It's not like everybody stays isolated in their buckets by their counties, but it's important to consider the big picture too.
Got it.
Yeah, each county is a little different. Vaccination rates are very different. We have some counties where it's only 40% vaccinated. We're up in the 70s. That's a huge difference in terms of what transmission would look like. So it is important to take in as much of the picture as you can. And then Debbie had a question. Yeah.
I had a question because Katie was showing her N95 mask and it had ear loops. Well, I just bought some N95 masks from Amazon because I'm flying next week and I'm just like a little nervous. I thought, okay, the airplane, at least I want to wear that.
Yeah.
But it has the one that goes in the back of the head and it's not that comfortable.
No.
If I altered it, will it be as effective or should I not do that? But I saw Katie's had the ear loops.
Yeah. So some of the KN95s have ear loops and they are more comfortable. That's frankly what I use.
Yeah.
You know, being on an airplane and something, if you're especially if you're going to the south anywhere, I would still use the big one with the loops over the head. I would want the real, you know, the big guns. But
okay, so that's a little different one, the KN95 than the 95 or then the N95
is approved by OSHA. It's met all the all the criteria to be officially an N95 mask. The KN95 is kind of like the emergency use authorization mask. So they're manufactured using similar processes, but they aren't the official N95 masks. So they're ones that are manufactured with the same intention and the same standards, but they haven't been proven on the market the way that the N95s have, if I'm saying that correctly. Does that jive with what?
Yeah, I think I'll probably wear it just on the airplane and then go back to my surgical mask.
That's what I've done. When I traveled to California to see my parents, I used the big gorilla mask for the airplane and then went to my more comfortable KN95 with the ear loops for the rest of the trip. Yeah.
Okay. And are those the KN95s? I think I've seen even like at Home Depot and stuff with that.
Yep.
Those would be fine. Okay.
Yep. Amazon carries a bunch of different types. If you're a nerd and you want to be 100% certain, you can look at OSHA or NIOSH, and they have a list of approved manufacturers. So if you really want to go the extra mile, you can look up and make sure that that manufacturer is on OSHA's list of okay manufacturers. But most of the stuff that you can get, definitely the stuff at Home Depot and Lowe's, you know, the home improvement stores, those are good because they're used for construction grade issues.
Okay.
Yeah.
And I would just say, Debbie, I mean, I don't recommend altering anything, but the key to the operation is if it's comfortable, you'll wear it. If it's uncomfortable, you'll be monkeying and stuff, and that kind of defeats the purpose. So if you can make it so it's comfortable and you got a good seal, I mean, this is being recorded. The OSHA will not.
One thing I'm a heavy
for a short period. You could just tough it out. Yeah.
But I am a heavy water drinker. So I will probably sneak it off for a few times. And I keep thinking I could see the whole thing like popping off and then having to readjust.
Across the back.
Whereas with the, you know, if you just go like this, that's easier to get it back. Yeah, that was my thought.
It's okay. Katie's point is really good. And it crossed my mind back when I was talking about masks and I didn't say it out loud. Is the most important mask is the one that you'll actually wear and wear with the best fit it can give you. Yeah.
You can stick a straw underneath and minimize. Do you know what I mean?
Yeah.
Just minimize the off time. So like you have your beverage and you put a straw in and you just kind of tuck it under.
Oh, okay, I've never tried that. Well, I don't have any straws. That means I have to go buy
And
some
just in the
straws.
fairness of completion, when you are sitting in your seat and belted in your seat on the plane, that's actually pretty safe. You have some of the best air exchange that any of us will ever encounter because yeah, Katie's doing a little demonstration.
Oh.
But on airplanes is
And that's actually going in your mouth, Katie?
yeah. Air exchange on airplanes is incredibly well managed. So it comes from the top, they entrain outside air and it comes down and it goes down and goes down to the vents. And so you can, I did this even before COVID. I also immediately, when I get in my chair, I turn on my fans and have them blowing kind of down and away from me to kind of prevent almost like a curtain, a blowing curtain.
Okay.
And so once you're belted in your seat, if everybody else is staying belted in their seat, you're actually quite protected, other than maybe for the one person next to you here.
Yeah.
So save your eating and drinking for when you're seated in the plane and belted in. But if you can, that's another way to kind of minimize your exposure.
Okay.
Yeah.
Well, it's only 2 hours, so I shouldn't have to eat.
2 hours. Yeah, you're good. 2 hours.
But I'll probably will need water. I can't go more than 2 hours without water.
You were allowed to keep your health going with that too. Yes.
I'm just,
Tom, did you have a question?
On the mask issue,
Yes.
how long can you use a reusable mask?
Katie? Katie knows more. Katie has more direct experience with
No, you know what? It's a good question. I probably reuse mine just because the reduce, recycle.
Yeah.
What makes it more permeable is if it gets damp, which is normal with, you know, you exhale. So I put mine out on this in the sun at the end of the day and it dries it out. And I feel okay wearing it for, you know, a couple of days.
Okay.
What about the N90?
There's probably an official word, but this is crazy. Way back in the day when we were first going into precautions, like a year and a half ago at the hospital, we would put our mask in a bin and they'd like run it through an autoclave for surgery, you know, just so we would, because we were just going through them so much. And others said like, oh, put it in the oven at 200 for like 10 minutes. And but I think the big thing is just that getting wet for whatever reason will make it more permeable and potential. But you know, wearing it for a couple of days, getting a couple of days worth out of a mask, I don't think is a problem.
That's what I do. That's my practice. I use one for two or three trips, kind of out of the house doing running errands or whatever. But I do hang it on a hook so that it's just sort of hanging in open air, so it does get as dry as possible. And if there's any visible soiling, obviously done.
Yeah.
And then the other thing to be cautious about is that, of course, each time you wear it, the loops get looser. And so if you start to notice that you're not getting good fit anymore, then it's time to get a new one.
Yeah.
If you're not getting good kind of pressure with it. Yeah, Tom.
One other related question, kind of. When the FDA does their evaluation of a vaccine, how much do they rely upon the manufacturer's data versus their own?
So the manufacturer's data is the initial data. So that's kind of the first threshold that has to be achieved. And so that's only the first threshold. Once that's achieved, then there has to be a study done, not by the manufacturer, but by different institutions, different medical institutions. And then that's when they start recruiting volunteers, and then they have the volunteers get the shot, the bigger group. So the manufacturer does a small group. And then once that looks okay, then it's time for the bigger group. And the bigger group is done at different medical centers, at different, you know, health clinics. And so that sort of builds upon the manufacturer's numbers, but verifies it, but does it with a bigger group of people. That makes sense. I'm not sure I explained that well.
Yeah, no. Okay. At least it isn't the majority of the data the FDA looks at is their own data.
Correct. It's they're running studies and getting information from studies that are not run by the manufacturer. That's not the sole source. It would never be the sole source. So it's necessary as the first threshold that looks okay, but then it goes beyond that.
Johanna has a question.
Yeah.
And I am unmuted. Thermometers. Is there really any use to like trying to take somebody's temperature?
Well, I'll tell you my opinion. Katie might contradict me, but I personally don't think there's much benefit to it. I think that by the time someone were sick enough to run a fever, that person would already know that they're sick with something. And so I think it is, there are other ways to spend your energy that are more beneficial in terms of
Getting into a building.
preventing, unknown exposure.
And you can take some Motrin or Tylenol and
That's a good
knock
point.
that fever out and still have COVID. So yeah, I agree too.
All right.
There's other things to look at. Yeah.
That fits with, what I had read before, and I just wanted to check and make sure that that's.
Yeah.
Are there things other than HEPA filters that one can do to improve air handling?
I mean, any ventilation helps. And so if there's any way to get even just cross ventilation from outside air, that helps. So that also helps. So if you can have windows on both sides open of someplace, or if you're going to be in a car with someone, if you have all the windows down, any kind of ventilation is good. That helps. But particularly being able to put it through a HEPA filter helps scrub the air and get those particles out of the air. But the ventilation keeps the air moving, which means it's less likely that enough is going to accumulate that you can be exposed. That makes sense. Did that answer the question? Is that what you were asking?
I think, yeah, that answer. I had also read about upper room UV. In like some hospital lobbies, for example, where ER lobbies, and some other things, and is effective against spread of tuberculosis, for example. But it's also a really expensive technology, and I didn't know if in the intervening months that there had been any advancements in that area, things you can do.
I don't think so. The other sort of, it is now popping into my mind, the other kind of sort of DIY HEPA filtration option that you can use for ventilation. There's something called, I'm not going to be able to spell it. I'll try to look it up and I'll get back in touch with you, Johanna, with it. But it's a McCorsey, but you can take a regular fan and use a filter and attach it. It's kind of like we make swamp coolers in the summer to, sort of like a fake air conditioner. You can kind of do that and sort of make almost like a HEPA filter by using just a regular air filter attached to a fan and set up a certain way. If I can find it, I'll send you the link to that.
Did a lot of that last summer with all the smoke.
Yes, exactly. The same stuff that gets rid of smoke. That's exactly it, because that's the size of particles that are aerosols that you worry about with infection. So anything that would cleanse cigarette smoke or wildfire smoke is also going to work on COVID bugs.
Well, thanks.
Yeah. All right.
We're also moving past our hour, so I don't know. Maybe we could do a last call on questions, or Katie and Amy, you guys are the ones. So let us know what your time needs are.
I was just going to say one more thing, but yeah, any questions, or does even after that we say goodbye, via emails or snag me at church or whatever. Happy if I know the answer, or if not, I can find out. I kind of, what Charlotte was mentioning about her son kind of prompted this. Most people that get COVID aren't critically ill. So if you do get a diagnosis of COVID, don't go to the pharmacy and get a vaccine at that point. While you're still infected, because you're still infected, and all the gang at Walgreens won't appreciate you coming in being COVID positive, and you won't get the bang for your buck. You're already fighting that infection. Wait like 3 months, get your vaccine at that point. Is that fake news, Amy, or what do you think?
No. I mean, anyone who tests positive should be quarantining or isolating. They should.
Even if you feel like, hey, I'm not too bad, I'll just go get the vaccine now that I know that I have it. We do offer the vaccine at the hospital, obviously for people that are not COVID positive. And mixed bag. Some people go for it and others don't. But if you're there for like a trauma and your pelvis is broken and legs, that's not going to affect your treatment for your pelvis and legs to have that. So that's an option out there too. Yeah.
And if you're concerned about your risk factors, I mean, I encourage people to work on their risk factors. So if you have high blood pressure, start going for walks every day. See if you can get your blood pressure down. You know, it's normal for us to have some anxious energy around concern about, oh my gosh, am I going to get COVID? If I do get COVID, am I going to get especially sick? And harnessing that and using it as a way to motivate yourself to maybe improve your health a little bit overall is wonderful. All right. Well, I think we've covered what people need to cover today, but I agree with Katie 100%. If anyone wants to reach out to either of us or both of us by email or to the church office, we are happy to work on getting answers that we can.
Thank you so much for taking
Thank
the time
you.
to do this.
Yeah.
Really
Well, thank you,
appreciate it.
Thank you so much.
Yeah. Appreciate everybody.
Okay, have a good day.
Yes.